cover some of this material for you, and we're going to go ahead and get started. I would like to tell you guys that you're going to have a moderator, Courtney. If you joined us a couple of weeks or last week, you would have seen her doing our standalone practice question. So she's going to be in the comments just kind of answering any questions that you guys have. And my name is Emily. I'm one of the co-creators here at NCLEX Bootcamp. And my favorite subject is cardiac, and I think my hardest subject is OB. Cardiac I love. I've been an ICU nurse for over 10 years with all of my experience in the ICU, but specifically cardiac ICU will always have a special place in my heart, no pun intended. But yeah, I'm so thrilled today to be talking to you guys about what's on the next generation NCLEX, and I'm going to ask you guys several questions throughout. Please leave your comments on the video. We would love to kind of hear from you guys, and if there's a little bit of a delay, I'm not ignoring you. It just takes a couple seconds for me to see the comments on my end. But Courtney there is going to be answering any questions that you have, and also leaving some helpful links and some information about our giveaway since you guys have joined us today. So we are going to be talking about what's on the next generation NCLEX. And of course, to understand that, we need to understand the purpose of the NCLEX, because that's going to help you understand why you're seeing this material. Then we're going to look at what the top 5 client need areas are on the NCLEX, and we're going to spend most of our time doing some live practice of the top client need area. So first, what's the purpose of the NCLEX? And how many of you guys have heard someone say that the NCLEX is a safety exam? Is that something that you guys have heard before? And I think probably all of us have heard that, right? And that's because it's true. The goal of the NCLEX for you guys might be to get your RN to pass, but the ultimate goal of the NCLEX is to protect the public. And so they do that by administering the NCLEX, and once you pass and once you get your RN, what that means is they've decided with a 95% confidence interval that you are going to be a safe entry-level nurse. And that's what we all want to be. We want to be safe nurses and not scary nurses. And so the fact that you guys are all here today to learn, I think, just demonstrates that you are going to be those safe nurses, and we believe that you're going to pass. And so thanks for joining us. You're going to be safe entry-level nurses, and they define entry-level, just so you know, as a generalist nurse within the first 12 months of practice. So not a specialist nurse, not somebody who's been in some specialty area for 10, 15 years. They're going to ask you really broad, big picture questions that are safety focused. And we're a boot camp all about giving you the most important, most useful information. So that's what we're going to be focusing on today as well. So then, in order to figure out what topics are on the test, you guys might not know, I actually didn't until I finished nursing school and had already taken my NCLEX, but there is an official NCLEX test plan. So this is something that every 3 years the NCSBN surveys actual practicing nurses, and they want to know from them, what are the things that you do most frequently in your day-to-day practice, and what are the things that you do in your job that are most important, and what requires the most clinical judgment, or that thought process of thinking like a nurse. And so based on the responses of actual practicing nurses, they decide that one of the most important areas is clinical judgment, which we're going to focus on today and makes up your case studies. And then the remainder of the test is broken down into these client need areas. And this might not be language that you're familiar with because your courses in school might have been organized differently, but you guys know what's here. So management of care, that's going to be your prioritization, delegation, assignment, but also just making sure that you're able to protect your clients' legal and ethical rights. Then safety and infection control. So obviously our patients are vulnerable to injury, they're vulnerable to getting a healthcare associated infection. And so this is about using the right PPE and safety precautions and making sure that we're keeping them safe. Then health promotion and maintenance. So this is, are children developing appropriately? Are patients being screened for disease prevention, getting vaccines, things like that. Then psychosocial integrity, that's your therapeutic communication, of course. Basic care and comfort, so the things you learned first semester in fundamentals, so hand hygiene, mobility, repositioning to protect your patient's skin, and that sort of thing. And then pharm, everybody's favorite subject. Reduction of risk potential. So there's always a risk associated with anything that we do for our patients. So if we put a Foley in, they're at risk for a UTI, right? So preventing that. If they get a surgery, there's risk of complications from anesthesia. And so just preventing complications mostly. And then finally, physiologic adaptation. So this is kind of your nursing process, assessing and intervening on all the common disease processes and OB situations. So that is what is on your test. And when we actually look at the breakdown for what the top 5 client need areas are on the NCLEX, these 5 make up over 70% of the exam. So these are your big guns right here. And that's going to be number 1, clinical judgment. So clinical judgment items on the NCLEX are in the form of your case studies. So if in a minimum length 85 question test, you guys get 3 case studies that are 6 items each, that's 18 items. So that's about a quarter of your test. So this is one of the most important things on the NCLEX, and it actually is the big difference between the previous NCLEX and the new NextGen NCLEX, is they realized we have got to test students' ability to think like a nurse. And so that's what we want to help you with here today. And then the other client need areas are your management of care, so your prioritization, delegation, assignment, your pharm, of course, physiologic adaptation, and safety and infection control. So at some point, if you guys keep coming to our webinars, you're going to get all of this content, but today we are going to focus on this clinical judgment piece, since that's our number 1. And at Bootcamp, we really want you to study smarter, not harder, and so we're going to focus on the most important thing today. So the way that the NCLEX measures clinical judgment is using this 6-step clinical judgment measurement model. It's very simple. Basically, you've got a 6-question case study, and each question in the case study corresponds to one of these steps. And it might not be familiar to you, but you're probably familiar with the nursing process, your ADPI, right? And it really roughly correlates between the two. So you're going to be assessing which cues are most important, analyzing what they could mean, and then kind of forming a care plan and prioritizing what you're going to do about it, and then taking that action and following up or evaluating to see if it helped. And so we are going to get into a different item from our question bank that kind of represents each one of these thought processes. And of course, on the real test, you're going to see these in the form of a case study, but just for the purposes of going through stuff easily together today, we're going to look at your multiple choice and SATA questions, because that is still going to make up the bulk of your exam. Those item types will. All right, so we're going to look at these together, the clinical judgment items. So first is going to be recognizing cues. And that's really important for you as a nurse to be able to recognize what is most important, because no patient in front of you is ever just going to have one problem, right? They're going to have like 10 things and 5 symptoms, and they're on their call light, and you have got to figure out what is most important here. What do I need to follow up on, and what can I defer or wait or ignore even? So that's the first thing we're going to be looking at. To figure out recognizing cues, we're going to practice recognizing cues here with a patient who has got severe COPD. So we need to figure out which of the following findings would require immediate follow-up. So when you guys are asked about immediate follow-up, that means you are looking for an unexpected abnormal finding that you need to do something about, right? And so in order to figure out what's expected versus unexpected with COPD, let's just do a quick little refresher on what COPD is. So in COPD, you've got kind of this overlap of chronic bronchitis and emphysema. And I bet you guys know and you remember what the number 1 cause of COPD is. So leave that in the comments there. I want to make sure that you guys can remember that, because it's an easy one. But ultimately, it's smoking, right? And so there's no safe form of tobacco. The longer you smoke, the more damage this does to your lungs. And so it's going to increase this inflammation and mucus production, and that is going to kind of narrow the airways and limit airflow in, ultimately causing hypoxia. And then the other effect that it has is that it destroys the elastic tissue here in the alveoli. And so healthy alveoli, the second that it inflates, kind of like a balloon, and you let go and let the air out of the balloon, it should immediately collapse. With COPD, it loses that elasticity and it's kind of more like this like floppy paper bag. So nothing can easily get out. So that's our big problem, is we can't really get air in or out. We have limited airflow. So then which of these findings, knowing that, would require immediate follow-up? So first, lower extremity edema. So why would a patient with COPD have lower extremity edema? Do you guys remember why? So we'll talk about this. So basically, a long-term complication of COPD is something called cor pulmonale. And all that this basically means is it is heart failure that is caused by a lung problem. And so basically over time, this kind of constricted airway, this raises the pressures in the lungs, and so the heart has to work harder to pump blood to the lungs. And so then this can strain the heart and cause heart failure. And so another question for you guys, would this cause right-sided heart failure or left-sided heart failure if you've got cor pulmonale? So yes, right-sided heart failure, because the right side of the heart or the right ventricle is what's pumping blood to the lungs. So if we see lower extremity edema in this patient, that means that they've probably got this long-term chronic complication. But there's really nothing I need to do about it right now, right? If there were other signs of heart failure, like maybe pulmonary edema, restlessness, pink frothy sputum, then I would need to immediately follow up on it. But if it's just lower extremity edema, we can prop their feet up later and they're going to be fine. So it's not this one. Then paradoxical respirations. How do you guys feel about this option? So if you don't know what paradoxical respirations are, I want you guys all to kind of take a breath right now, just in and out, and notice that your normal breathing pattern, when you breathe in, your chest wall and abdomen rise, and then when you breathe out, they fall. And so that's normal. Paradoxical respirations are the opposite. So when the patient breathes in, their chest wall and abdomen kind of suck in, and when they exhale, they go out. And so this is paradoxical. And is this normal in COPD? This is not normal in anybody, I'll tell you that. So in COPD, what kind of respiratory pattern would you expect them to have? Like when you look at them, what do their respirations look like? What are they doing? What position are they in? You guys probably remember that they would tripod, right? That tripod position helps get the air in, and they might do some pursed lip breathing. That helps get the air out. And so we would maybe expect to see them tripoding. We would expect to see them doing pursed lip breathing. But if you ever see paradoxical respirations on the NCLEX, I want you to think of that as a warning sign. This is a danger signal that the patient has got increased work of breathing and they are working way too hard to breathe. So I never want you guys to ignore this. I'm not going to ignore it here, and I'm pretty sure this is our right answer, but let's consider our other options as well. So, okay, an increased hemoglobin level. Do you guys remember why this happens in COPD? So basically, when you've got this chronic hypoxia, this low blood oxygen, your body kind of increases the production of red blood cells to try and carry more oxygen around through your bloodstream. And so it's normal, it's expected, it's a compensatory mechanism, and there's really nothing at all that we need to do about it. Then a pulse oximetry reading of 88%. Is this normal? So it's normal in this patient, right? Do you guys remember what the normal acceptable pulse ox range is for COPD? So it is 88 to 90%, right? These people kind of live with COPD at a lower pulse oximetry rate, and that is expected. Just give them some time, coach them through pursed lip breathing, and they'll come back up. So this is normal as well. So out of all of these, the only one that's going to require immediate follow-up, and it should always warrant immediate follow-up on the NCLEX, and that is paradoxical respirations. And we're correct. And as you can see, only about half of our users in our bank got this right. So you guys who got this one right are already kind of ahead of the curve, above average. So well done. All right, so now that we have recognized the cue and figure out what's most important, the NCLEX also wants to know that you can analyze cues or figure out what could it mean and kind of connect those signs and symptoms to specific disease processes. So here we're being asked to analyze cues and see if they support a diagnosis of chronic venous insufficiency. All right, so here this is a very common thing you're going to see on the NCLEX, where they want to test that you understand the difference between venous problems and arterial problems. All right, so let's do a quick review of those differences. So these are opposite problems, peripheral artery disease and chronic venous insufficiency. And in peripheral artery disease, we have got impaired blood flow to the distal leg. This is from atherosclerosis and narrowing these arteries, right? So you're going to see symptoms of lack of blood flow. And this is where your kind of 6 Ps come in here. Your leg is painful, it's pale, it's cold, you might have pulselessness. That makes sense, it's not getting enough blood flow. And then when you have ulcers, because you have ulcers in both of these, they're going to be on the most distal part of the foot because that's where we have the least blood flow, right? That's the most problematic part. So you're going to see those show up on the toes, on the top of the feet, maybe the shins, and that's peripheral artery disease. And then we're also going to look at chronic venous insufficiency. So in chronic venous insufficiency, this is the opposite problem. So in this case, we have got a lack of blood return from the foot. And so you're not going to see signs of arterial insufficiency. You're going to see basically venous stasis. So you are going to see blood pooling in that lower extremity. And so the most recognizable symptom for this is just going to be edema. We've got blood return that is halted because it can't get back up through these valves, and you start to swell. And so you're going to see swelling, heaviness. When you do get ulcers here, because your foot can only swell so much, it's mostly the calf and leg that swells, you're going to see those ulcers more higher up. So on the ankles, the lower leg, and the calf. All right, so now knowing this, let's consider which of these findings would support a diagnosis of chronic venous insufficiency. All right, so the first one, absent pedal pulse. Is that going to be an arterial problem or a venous problem? What do you guys think? Give you a second to think about that one, absent pedal pulse. So yeah, that one's pretty easy, right? We've got pulselessness, and that is a feature of arterial insufficiency, not venous insufficiency. So it's not this one. Then intermittent leg cramping with exercise. What do you guys think? Is that an arterial or a venous problem? So yes, you might remember the term intermittent claudication, and that is a feature of arterial disease because when you walk around, your muscles are using the oxygen, and then when the oxygen runs out, it can't get new blood flow, and so it cramps. So this is an arterial problem. Then ulcers on the toes with well-defined edges. Is that a venous or arterial problem? So yeah, remember, arterial ulcers are going to be on the most distal part where the blood flow is lowest. So those are on the toes, shins, and the foot. So that's going to be an arterial problem. And then our last option here is brown discoloration to the lower extremities. And we didn't talk about this, but I think it's going to make sense when you think about it, that with chronic venous insufficiency, when you have got blood pooling in the leg instead of returning to the heart and being circulated through the body, your red blood cells start to kind of die off and they release their contents. And one of the contents of red blood cells is iron, right? And so in chronic venous insufficiency, you can kind of see this iron coloration called hemocysteine deposits showing up on the legs. And so I like to think of this as it's like it's rusting, right? The blood is kind of pooling, stagnating, just like an old something that's been sitting out would rust. And so when you see this brown discoloration to the lower extremities, that is a sign of chronic venous insufficiency. So of these, we've got 3 arterial and 1 venous problem. So I hope you guys got that one right. And yeah, only about, again, half of our users in our question bank got this right. So again, you guys are above average and doing great. Good deal. So now that we've analyzed what these cues could mean, the NCLEX also wants to know that you can prioritize hypotheses or figure out where to start. And this is important because we always have more things to do in practice than we have time to do them. So we need to figure out, what do I do first? And before we look at this next question, I want to give you kind of a hypothetical scenario. Maybe say you are a neuro ICU nurse, all right? And you are called by the OR and told that you're getting a patient who just had a craniotomy. And what complication do you guys want to prioritize that patients are at risk for after a craniotomy? So what's our number one complication we're worried about after craniotomy? I hope some of you guys said an increased ICP, right? When you operate on the brain, you can have some swelling that increases the pressure in the head that can limit blood flow and cause stroke, coma, and even death or seizures, right? So that's our priority hypothesis. So if we have got a patient who is at risk for increased intracranial pressure, which then of these assessments should we prioritize in their plan of care? So I think you guys got this one, but let's read the options. So should we prioritize the Babinski reflex, the presence of headache, the pupil size and reactivity, or the level of consciousness? This is a really common thing NCLEX likes to ask, so I think you guys should know this one. And obviously these are all assessments we're going to be doing. These are all part of a neuro assessment, but there's only one we're going to prioritize. And so is it the Babinski reflex? So the Babinski reflex, remember, tells us about spinal cord injuries. And what's normal? Just quick question. If you assess the Babinski reflex, is it normal in an adult for the toes to fan out or for the toes to curl under? Yeah, so a normal Babinski reflex in an adult is for the toes to curl under, right? But that would only tell us about a spinal cord injury issue, not really about increased ICP. So it's not this one. Then the presence of a headache. Well, would you have a headache with an increased ICP? Yeah, sure. But you would also have a headache because you just had head surgery, right? And so that won't really tell us that they have increased ICP. It may be there, it may not. And so this isn't as useful because it could be an expected finding in this patient. So it's not this one either. Then pupil size and reactivity. Will this tell us about whether they have increased ICP? Yes, it will, right? We say that the eyes are kind of the window into the brain. You're always going to see in the late stages of increased ICP, those fixed dilated pupils. But that key is the late findings. So at the time that we recognize they've got fixed and dilated pupils, it's probably too late for us to do anything about it or to get the surgeon to take them back to the OR for a drain, right? So this is not as useful as our number 4, and I hope you guys got this one, level of consciousness. That is a really good NCLEX tip that changes in level of consciousness are the earliest and most sensitive indicators of an increased intracranial pressure. So if your patient starts to get lethargic or drowsy or they're disoriented, that needs to concern you for an increased intracranial pressure if this patient is at risk for it. So great job, you guys. And this one's a little bit more easy at 80%, so I hope you guys will remember this one as something that is a need to know for the NCLEX. Good, so now that we've prioritized what we're gonna do first, we need to generate solutions or figure out what can I do to address this problem. And so we're going to look at this client who just had a coronary angiography via a femoral artery approach, and we need to figure out which of these interventions we include in the initial post-procedure care. So real quick, do you guys remember what a coronary angiography treats? What do we do this to treat? So yeah, this is done to open up the coronary arteries, and we do this either routinely for someone who has coronary artery disease, or we can do it emergently if someone's having an MI. And what's done here is the provider goes in and makes an incision here in the femoral artery and threads this catheter up to the coronary arteries. They inject a lot of contrast dye so they can visualize where the blockage is, and then they open it and stent it open to hold it open and restore blood flow. All right, so knowing that then, which of these interventions should the nurse anticipate in the initial post-procedure care for this client? Should we put them on a fluid restriction? What do you guys think? So keep in mind here that they just got a lot of IV contrast, and there's one organ in the body that hates IV contrast more than any other organ, And I think you guys know what that is. What organ is that hates IV contrast? And it is the kidneys, yes. That is the number one cause of acute kidney injury is contrast nephropathy, from getting IV contrast. And so the way that we can prevent it in this patient who just got a ton of IV contrast is to give a lot of IV fluids, or if they're just taking oral fluids, a lot of oral fluids. So no fluid restriction. That is going to increase their risk for acute kidney injury. Are we going to monitor the puncture site for swelling? So yes, remember we just punctured one of the largest arteries in the body, and they get a ton of blood thinners before they do this procedure, right? They get heparin, they get aspirin. So we gave them a ton of blood thinners and then punctured an artery. So they are at high risk for bleeding, and that is something we definitely want to watch for after this procedure. And so that could be local, where we would see swelling and it would kind of bubble up like a hematoma, almost like a tennis ball size thing. So that's definitely important to do. Then placing the client on continuous cardiac monitoring. Well, yeah, that's really important. We just went in and kind of tickled their heart, right? We don't want to miss any dysrhythmias, or if that stent collapses, it could cause another MI or a first MI. So this is always important to place the client on cardiac monitoring after an angiography. Then should we assist them up to the chair to prevent atelectasis? So this is a very common thing after surgeries that we do, is we get patients up out of bed, we ambulate them, and that's done to prevent atelectasis. But this client who just had their femoral artery punctured, if they get up and walk around and sit down in a chair or even bend at the waist, that is going to put a lot of pressure on this site, and that can open up that artery that we're trying to clot off. So these patients need to be on bed rest. And do you guys remember how long they need to be on bed rest for? Okay, it's about 6 hours. All right, and so that's a long time to lay totally flat and keep your legs straight, but it's really important because they are at high risk for bleeding. So we can have them do some deep breathing exercises laying flat if we need to prevent atelectasis, but they should not get up until that bed rest period is over. Then should we palpate the client's pedal pulses every 15 minutes for the first hour? Yes, we should. We need to be down at their feet, assessing those pedal pulses. And if you have a weak pedal pulse on this side, that could mean that instead of the blood traveling down to the foot where we're trying to feel for it, it could be leaking out into the abdomen, into the leg. And so this is an important part of the monitoring. You're going to get very friendly with this patient by the end of your shift, because every 15 minutes you're going to go in, you're going to pull their covers aside after you warn them and look at their groin site and palpate their pedal pulses. So this is also important to do. So very good. And we got about 80% of points average on this one. So well done. All right, so now that we have figured out what we can do, we need to actually do the thing. We need to take the action, and this is, really important to do as a nurse. You need to know how to intervene, especially in a scenario like this one, which is kind of emergent. And so we have got this patient. We review the diagnostic results for this client who became unresponsive and has no palpable pulse. And then you observe that they have got gasping respirations. So let's take a look at our diagnostic results. And so this is what you see on the monitor for this unresponsive patient with no pulse who has gasping respirations. So if you walk into the room and you guys see this on the monitor, what are you going to say? So you're going to get help is the first thing, right? We always want to get help whenever we can see an acute change in patient condition, activate that emergency response system. I would say something that I can't share with you here because we're trying to keep this PG-13, but it would be something like, oh no, right? And then, can I get some help in here? And so we've got this patient, unresponsive, no pulse, gasping respirations. Do you want to either initiate chest compressions, give IV push atropine, obtain a 12-lead EKG, or deliver rescue breaths with a bag valve mask? What do you guys think? So here's a hint. The only real piece of information that you need to answer this question is this one, no palpable pulse. It doesn't matter what their EKG shows if they have no palpable pulse. It doesn't matter if they still have respirations or not if they have no pulse. If they have no pulse, they need one thing, and I hope you guys know what it is. It is to initiate chest compressions, high quality chest compressions as soon as possible, because every second that you delay that, the patient's not getting any blood flow to their brain, right? So that's really important, but why might we have fallen for the other ones? Let's see. So administering IV push atropine. So atropine is given to treat bradycardia, right? But if the patient is pulseless, we don't really have bradycardia. We have something called PEA, pulseless electrical activity. So we have electrical activity that looks normal on the monitor, but if we have no pulse, this patient needs CPR, end of story. So not this one. This one's for more stable bradycardia with a pulse. Then obtaining a 12-lead EKG. It kind of doesn't matter what the EKG shows, right? If they don't have a pulse, they need CPR. Also, this is going to take a long time to do. You have to hook up 12 stickers to them, and that's just going to delay time and cause further brain death. So it's not this one. Then delivering rescue breaths with a bag valve mask. So that's going to be helpful if a patient just needs rescue breathing, like, for example, if they had an opioid overdose. But that's not going to help restore their pulse and circulate their blood. Only the chest compressions are going to do that. So that is the action that we should take. All right, good job. Only about half of people. So keep this in mind. Patient has no pulse, do CPR. Don't forget that, you guys. That's going to come in handy one day. All right, then finally, evaluating outcomes, or looking at everything that we did and deciding, did it help? Did we see the right change in vital signs, symptoms? Or maybe if we taught the patient something, did they understand that teaching when we evaluate it? So that's what we're going to look at here. Is we've taught a client who is scheduled for a total laryngectomy, and we're evaluating their statements to see which of these require follow-up, or which of these requires us to correct them. Okay, so even if you guys don't know what a laryngectomy is, you know that ectomy means we've taken something out surgically, like the surgical removal of something. So in a laryngectomy, what did we remove surgically? What is this? So it's the larynx. We've surgically removed the larynx, which is the voice box right here. And this is usually from smoking. They get laryngeal cancer, and that's removed to remove the cancer. So which of these statements would require follow-up? Will the patient have to practice using a mirror to care for the stoma? So yes, a major consideration for this surgery is that it causes a lot of body image changes for the patient. They're going to have a stoma. It's a very visible thing right here on your neck, and so it's very important that we start getting them to use a handheld mirror, to visualize it, to start to care for it, to just get accustomed to their new body image. So this is correct. There's nothing to follow up on here. Then when I'm discharged from the hospital, I won't need a feeding tube. So that's fine, right? That's correct. They are not going to be limited in their ability to chew and swallow. They still have their tongue, they still have their teeth. So unless we removed something else, they don't need a feeding tube and they can eat normally. So this is fine as well. Both of these are normal. Then my husband has bought me some scarves to wear loosely over the stoma. Is that okay? Yeah, this is fine. It can seem scary, but as long as it's loose and it's loosely draped, we might worry if it's really tight or it's like a dirty scarf and it could get infected, but just a loosely draped scarf could really help that patient adjust to their new body image with that stoma present on the neck. So this is fine. It's also fine after thyroid surgery on the neck as well. So you might see it that way on the NCLEX. Then finally, after the surgery, my voice will be hoarse but will eventually return to normal. Does this statement require follow-up? Yes, it does. So regrettably, after they have got their voice box removed, they will never have a normal voice again. So we can do something, they can have a voice prosthesis where they implant something and the patient can kind of manually change the direction of the blood flow, or I'm sorry, the airflow, so that they can create a normal sounding speech. It's kind of maybe a little robotic in nature, but it's not normal speech. Someone who has had their vocal cords removed is never going to have normal speech again. And so we want to make sure that we're managing this patient's expectations going into the surgery and that they know what to expect after they wake up, and they're not learning when it's too late that they are not going to have a voice again. So this one requires some follow-up. We need to probably get the healthcare provider back to the room, right, to kind of provide them some coaching on what to expect after the surgery. And all right, 41% got that one correct. So you guys did great. That was our final item for the clinical judgment steps. You can go look at our references here and find us on social media. But I want to take a second and ask you guys if you have any questions that I can answer for you, anything about the NCLEX, anything at all that I can help teach you guys, and I hope that you found this helpful today.